Welcome to the deep dive. Today, we're looking into a really critical piece of medical tech, mechanical ventilation.
Absolutely. It's a true lifesaver in intensive care. Essential stuff.
Totally essential. But as the material we've got here shows pretty clearly, it's complex.
Yeah.
And it carries some real risks.
That's right. We've got various sources here, papers, notes, excerpts, and they all dive into the potential complications. I mean, it's a powerful intervention, but it does fundamentally change things in the body.
And that's our plan for this deep dive. We want to unpack these hazards, understand why they pop up based on this material, and really pull out the key takeaways so you can quickly get what's most vital.
Yeah, think of it as getting to the heart of this balancing act between the tech and the physiology, using the details right here in front of us. Let's jump in.
Okay, so let's unpack it. The material kind of poses this core question first. Why do these complications happen at all when we're just trying to help someone breathe?
Well, one of the first points made is that, generally speaking, the longer a patient needs the ventilator, the higher the chances of complications. It's not usually just one thing.
Right, it's a mix.
It's a mix of factors. The material points to issues from the positive pressure itself, problems related to why the patient needed ventilation in the first place, the actual machine or the breathing tube, and even, human factors involving the medical team.
Okay, so a whole system view. Let's start with the lungs. That seems like the most direct impact. What does the material say happens right there?
Yeah, this is where it gets really interesting physiologically. We run straight into this concept called the VQ ratio, ventilation perfusion.
V ratio, right.
Think of it simply, like you need air coming in that's ventilation, V, and you need blood flow passing by to pick up the oxygen that's perfusion, Q. For it to work well, V and Q need to match up.
Okay, like supply meeting demand in the right place. So normal breathing.
When you breathe normally, spontaneously, the air tends to go more to the lower parts of your lungs, the dependent zones, and the outer edges. And guess what? That's where gravity pulls most of the blood flow too.
So a good match.
A good VQ match, exactly. It's efficient.
Okay, so how does putting someone on a ventilator, positive pressure ventilation or PPV, change that picture?
PPV kind of flips things around. Instead of air following the path of least resistance naturally, the ventilator pushes air in, and it tends to go more easily into the non-dependent zones, the upper parts, and the central airways.
The opposite of where the blood flow is greatest.
Pretty much. So in those upper central areas, you get lots of air, but maybe not as much blood flow. That increases the VQ ratio there. The material calls this increased physiologic dead space air reaching areas with poor perfusion.
Got it. Dead space. And what about the bottom parts, the bases?
Down there, in the dependent zones, you end up with the opposite problem. You have good blood flow, but now less air is being pushed there relative to the top. So you get a low VQ ratio.
And this low VQ, the material flags that as important.
Oh, yeah, definitely. It specifically says this low VQ is a key reason for an increase in the PaO2 gradient.
The A gradient. That tells you how well oxygen is moving from the lung sacs into the blood.
Exactly. A bigger difference, a bigger gradient, means oxygen transfer is less efficient. Something's hindering it.
So the ventilator disrupts where the air goes relative to the blood. Does it also affect the blood flow side directly?
It does, yeah. The material explains that the positive pressure in the lungs actually squeezes the tiny blood vessels, the pulmonary capillaries.
Squeezes them.
Yeah, increasing the resistance to blood flow through them. This can decrease the total amount of blood flowing through the lungs, which, again, adds to that dead space effect.
Okay.
And the blood that is flowing gets shunted away from these higher pressure areas towards areas with lower resistance. Often, those are the poorly ventilated zones we just mentioned.
So it makes the low VQ problem even worse in those areas.
Exactly. It worsens the mismatch and further increases that PaO2 gradient. It's a double whammy, really, affecting both V and Q.
Wow. Okay. It's a complex interplay. What other direct lung issues does the material bring up?
Well, there's hyperventilation and respiratory alkalosis. Sometimes the ventilator can be set, or the patient responds in a way that blows off too much carbon dioxide, CO2.
Making the blood less acidic?
Correct. The PCO2 level drops, the blood pH rises, and you get respiratory alkalosis.
And the consequences of that alkalosis, are they significant?
They can be, yes. The material lists few key ones. First, oxygen doesn't get released from hemoglobin to the tissues as easily. It's called a left shift of the oxyhemoglobin curve. Oxygen clings too tightly.
So even if the blood is oxygenated, it might not reach the cells effectively.
Precisely. Alkalosis can also mess with electrolytes, leading to low potassium or hypokalemia. That can cause heart rhythm problems, arrhythmias, or muscle issues like tetany.
Yeah.
And it can cause blood vessels in the brain to constrict, which might potentially reduce blood flow and oxygen delivery to the brain.
It's amazing how just a shift in pH ripples out like that.
Yeah.
And then there's the risk of actual physical damage.
Barotrauma.
Yes, absolutely. Barotrauma, that's injury, even rupture of the alveoli, the tiny air sacs, because of too much pressure or overstretching. The material is quite specific about pressures that increase this risk.
It gives actual numbers to watch.
It does. It mentions things like peak inspiratory pressure, or PIP, going over 40 centimeters of water, plateau pressure over 35, mean airway pressure, MAP, over 20, and PEEP, positive end expiratory pressure, over 10. These are flags for increased barotrauma risk.
And the material notes some patients are more prone to this.
Yes, it specifically mentions patients with conditions like COPD. They often have underlying lung issues like air trapping or weakened lung tissue that makes them more susceptible to damage from positive pressure.
Okay, so major impacts on gas exchange, potential for direct lung injury. But as you said, the material shows this isn't just contained to the lungs. Let's look at the wider systemic effects. Right, this is where you see how pressure changes in the chest affect everything else. Normally, the pressure inside your chest cavity, around your heart and the big veins like the vena cava, is actually slightly negative compared to atmospheric pressure.
Sort of a slight vacuum that helps pull blood back?
Exactly. It aids venous return. But PPV changes that. It makes the pressure inside the chest positive.
So instead of a pull, it becomes a push against the heart and veins.
That's the key. The material explains this increased pressure squeezes the right atrium of the heart and the vena cava. This makes it harder for blood to flow back from the body into the heart.
And that raises the pressure inside those veins.
It raises the central venous pressure, the CVP. Normally, CVP is quite low, maybe 2 to 6 millimeters of mercury. This low pressure creates a gradient, the material says around 10 millimHg, that helps drive blood back to the heart.
So PPV increases CVP.
It reduces that vital pressure gradient. Less gradient means less venous return, less blood flowing back into the right atrium.
And if the heart doesn't get enough blood back,
it can't pump as much blood out. The consequence, as the material points out, can be a drop in cardiac output, and if it's severe enough, low blood pressure hypotension. The breathing machine can directly impact the heart's pumping ability.
That's a critical connection. What influences how bad this effect gets, according to the sources?
Two main things highlighted are the overall average pressure being delivered by the ventilator, the mean airway pressure, and the patient's own heart and blood vessel health.
So, higher average pressures are worse for circulation?
Generally, yes. Things that increase mean airway pressure, like certain ventilator modes, higher pressures, longer inhale times, shorter exhale times, specific pressure waveforms, higher PEEP levels, or conditions like stiff lungs or blocked airways, they all tend to worsen this effect on venous return.
And the patient's condition matters too.
Right. The material notes that someone with a healthy cardiovascular system might compensate somewhat. Their heart rate might go up, or their veins might constrict a bit to help push blood back. But someone with existing heart problems might not tolerate these pressure changes well at all.
Okay, the body tries to adapt. Let's follow that blood flow. The kidneys come up next in the material. What's the impact there?
Kidneys are crucial, obviously, filtering waste, managing fluids, electrolytes, acid-base balance, clearing drugs. They get a huge amount of blood flow normally, maybe a quarter of your cardiac output.
And PPV affects that flow.
Yes, the material states that PPV tends to decrease blood flow to the kidneys, reduced renal perfusion.
Which would impair their function.
Exactly. Less blood flow means less efficient filtration. That can lead to decreased urine output, fluid retention, buildup of waste products, and in severe cases, acute kidney injury or renal failure.
And drug clearance is a big issue too.
Definitely. If the kidneys aren't getting enough blood flow, they can't clear drugs from the body as effectively. The material gives examples certain antibiotics like vancomycin, beta-lactams, aminoglycosides, heart meds like digoxin, muscle relaxants, diuretics like furosemide, others like procainamide, penicillins. Their clearance can be significantly reduced.
Wow, a long list. And sometimes drug levels can go up.
Yes, that's an interesting point in the material. For drugs that are normally reabsorbed by the kidney tubules to some extent, reduced overall flow might mean they hang around longer and get reabsorbed more, leading to higher blood levels. Aminoglycosides, theophylline, phenobarbital are mentioned.
And are there signs of kidney trouble to watch for?
The material lists indicators like urine output dropping below 400 milliliters in 24 hours, rising BUN and creatinine levels, standard kidney function tests, and electrolyte imbalances.
Okay, clear impact on kidneys. What about the liver and the gut?
Similar story with blood flow, really. Hepatic affects the liver also sees reduced blood flow, which impairs its ability to metabolize drugs and other substances. This effect can be worse with high levels of PEEP. Increased bilirubin levels might signal liver stress.
Makes sense. And the GI tract?
For the gastrointestinal system, PPV can cause reduced splanchnic blood flow, that's the blood supply to the intestines and other gut organs. This lack of flow can lead to mucosal ischemia, basically, the gut lining not getting enough oxygen, which can result in stress ulcers or other complications.
So it really is systemic. Lungs, heart, kidneys, liver, gut, all potentially affected by these pressure changes. What other complications are mentioned in the material?
Beyond those major organ systems, the sources mention broader issues. Infection is a big one. Patients might have reduced immunity, and there's the specific risk of ventilator-associated pneumonia, VAT.
Okay.
There's also the potential for physical and psychological trauma from the whole experience of being critically ill and intubated. And multiple organ failure is mentioned, although it's noted that might be part of the underlying reason the patient needed ventilation to begin with.
And then there are issues with the equipment or the process itself.
Absolutely. The material lists quite a few potential equipment-related or management problems. Things like the ventilator malfunctioning, alarms failing, the breathing circuit becoming disconnected, the breathing tube accidentally coming out or going down the wrong way into just one lung. Also, blockages in the tube, tissue damage from the tube itself, lung collapse or atelectasis from various causes, using the wrong ventilator settings, and even what the material calls misadventures, errors, stemming from misunderstandings or communication breakdowns. Plus, just the general risk of hospital-acquired infections like nosocomial pneumonia.
That's a very comprehensive list of potential downsides. But the material doesn't just list problems, right? It also discusses prevention. What strategies are highlighted?
Yes, thankfully it does cover mitigation strategies. This is about being proactive. A very basic but critical one emphasized is good hand hygiene. Before and after entering the room, touching the patient or equipment seems simple but vital.
Absolutely fundamental. What else?
Gentle suctioning technique for clearing secretions is mentioned to avoid causing coughing fits, aspiration, or damaging the airway lining.
Okay.
Positioning the patient is important too, keeping the head of the bed elevated, usually 30 to 45 degrees, the semi-recumbent position. That helps prevent aspiration and improves lung mechanics sometimes.
What about managing the ventilator circuit, the tubing?
The material advises against routinely changing the circuits just on a schedule, as that might increase infection risk. It also stresses managing condensation water buildup in the tubes. Either drain it carefully away from the patient, or, better yet, use systems like heated wire circuits or heat and moisture exchangers, HMEs, to prevent it forming.
Good points. And medication delivery through the circuit.
Yeah, the preference noted is generally for using metered dose inhalers, MDIs, rather than traditional nebulizers when possible, partly due to infection control. If a small volume nebulizer is used, it should be replaced after each use. Though it does note some newer nebulizer types might be as safe as MDIs.
Interesting. What about getting the patient off the ventilator?
That's a huge focus. The material strongly advocates for daily sedation vacations, interrupting sedatives to assess the patient's neurological status and readiness to breathe independently. This is shown to shorten ventilation time.
Makes sense. Wake them up and see if they can breathe.
Exactly. And alongside that, performing a daily assessment of their ability to handle a spontaneous breathing trial, the SBT, testing their capacity to breathe with minimal or no support.
And avoiding intubation entirely if possible.
Yes, that's mentioned too. Using non-invasive ventilation like CPAP or BiPAP masks whenever it's appropriate to avoid needing the endotracheal tube and mechanical ventilation in the first place.
Right.
And finally, regular, thorough oral hygiene. At least every 4 hours, the material suggests. This helps reduce bacteria in the mouth that could be aspirated into the lungs.
So looking back at everything we've covered from this material, it really paints a picture of mechanical ventilation as this incredibly complex balancing act. It saves lives, undoubtedly, but it fundamentally changes physiology and brings a host of potential issues.
It really does. And I think digging into these specific hazards from the source, VQ mismatch, those pressure limits for barotrauma, the knock-on effects on the kidneys, the heart, the liver, It gives you a much richer appreciation for just how careful and vigilant the management has to be. It's so much more than just pushing air into lungs.
That sums it up perfectly. So the key takeaways from this deep dive into our sources. Ventilation is life-saving, no question, but it carries significant interconnected risks affecting multiple body systems. And those proactive preventative measures we discussed are absolutely crucial.
And I think what the material really underscores is how intervening in a process as basic as breathing can ripple through our physiology in ways that are, frankly, quite profound. It shows how finely tuned our bodies normally are.
Absolutely. Which brings us to a final thought for you, building directly on what this material has shown us. Given this profound systemic impact of positive pressure, ventilation, how changing pressure in the chest affects blood returning to the heart, influencing kidneys, liver, gut function, what does that really tell you about the incredibly delicate, precise balance of pressures and flows your own body maintains? Almost invisibly, just breathing normally, long before any illness comes along. Something to think about.